Today, I'd like to talk about GammaTile for locally recurrent brain metastasis, dose escalation in the oligometastatic era. So, what is the oligometastatic era? It's not something that has been definitively coined, but it's mentioned every now and then. Essentially, what we're talking about is the era when we started aggressively treating low metastatic disease burden in our cancer patients. This happened through many innovations, including radiotherapy technological innovations, such as the development of stereotactic radiosurgery and stereotactic body radiation therapy, as well as adaptive external beam radiation therapy. And most importantly, the improved image guidance and targeting that technologies have been able to afford us as time has gone by. We've also had significant systemic therapy innovations, such as targeted therapies, such as EGFR receptor inhibitors, BRAF inhibitors, and then immunotherapy, as well as some various formulations of systemic therapy that has been made gentle enough to become maintenance therapies. What this has done is basically improve the control of the extracranial disease in particular. A lot of the agents that we use for systemic therapy in metastatic disease have some limitations on how much they can get past the blood-brain barrier, and so they don't have a high concentration in the CNS tissues like they do in the rest of the body. This has resulted in improved patient survival. This has also allowed there to be a greater time for a patient to develop brain metastases, and then having a greater time of being able to have intracranial disease. There is basically a greater chance for patients to have morbidity from CNS disease, more so than they did in the past. And overall, this is leading to the increased presence of brain metastasis. So essentially, we're looking at a situation where a lot of patients are having recurrent brain metastasis and often are having brain metastasis recur, needing recurrent treatment. At East Carolina University, we are very fortunate to have multiple forms of external beam radiation for the treatment of CNS lesions. We have a TrueBeam for LINAC-based stereotactic radiosurgery. We have a CyberKnife, and we also have a Gamma knife as well. So essentially, this has allowed us to be able to treat multiple patients with numerous brain metastases and recurrent disease in the past. Benefit that we found with GammaTile was that we ran into a situation where areas had been irradiated, whether it was LINAC-based external beam radiation or SRS, or Gamma knife, or combinations of multiple Gamma knife treatments, to a point that we were concerned about how much dose we were giving to the normal tissue by virtue of the radiation dose having to come from outside of the body to the target. GammaTile basically does not have this issue of what we call integral dose, the low dose to medium dose cloud that comes to the non-targeted tissue from radiation therapy. Here is an example of a patient that had a grade 3 glioma requiring adjuvant radiation therapy. They had very symptomatic scleroderma, which is one of the medical conditions that can be one that excludes you from having radiation therapy due to significantly greater complications. In the case of this patient, they had significant dermal involvement with alopecia, significant scarring. So we were extremely concerned about doing external beam radiation therapy. As you can see in the pane on the left, this is the result of applying GammaTile. And because of the shielding that the calvaria, the skull bone, offers in decreasing the dose to the surface of the scalp from GammaTile, we felt comfortable doing this, and in turn you can see that there's a very tight dose distribution, and there's not much dose going to the scalp, and in particular the healing scar, which is highlighted in green. We decided to see what the scenario would be if we were to use the external beam forms of radiation therapy that we have. And so the middle pane is a standard 60-ish grade treatment plan that we would have done on a standard linear accelerator. And then to make a better direct comparison, we treated approximately the same volume target-wise that GammaTile covered with CyberKnife, which would be a more tighter dose. And you can see in both instances here that there's a significant dose cloud introduced from these external forms of radiation therapy, and the scalp and scar are getting a significantly greater amount of dose. The other benefit that GammaTile has is that it really is getting more dose to the at-risk area of disease. For all these patients, we're doing craniotomies and maximal safe resection, and we're following it with radiation therapy based on the fact that there is microscopic disease that's left behind. Gamma Knife, of all the external beam radiation therapy platforms, offers the sharpest dose fall off that any of the other forms of external beam radiation have. However, once you get to lesions that are bigger than, a centimeter, centimeter and a half, that's when you want to start either using a lower single fraction dose that doesn't control disease as well, or fractionating. But most fractionation plans that are widely used in the United States really lead to a EQD2 at the resection cavity of only 60 gray. In comparison, GammaTile delivers that dose in EQD2 to 5 millimeters depth and is really treating the surface to 90 gray EQD2. So this is another reason that we're very interested in using GammaTile, not only because of the reduced dose that it gives to the surrounding tissue, but the significantly increased dose it gives to the high-risk regions for recurrent disease. With that being said, I'd like to talk about a patient case where we treated a recurrent melanoma to the brain. So the patient had a cutaneous melanoma to the left anterior chest, underwent a wide local excision, and had a negative sentinel lymph node dissection. He didn't have any evidence of disease recurrence for 8 years until he did develop splenic mets and liver mets, found on normal surveillance imaging, was asymptomatic, and was started on immune therapy. And this is what his PET scan looked at that time. It's a significant amount of the disease. And shortly afterwards, they did find some brain metastases on MRI imaging, had a 2.5 centimeter and 0.7 centimeter left frontal lobe lesion, as well as a 0.6 centimeter right frontal lobe lesion. This patient, unfortunately, was not seen by us at this point, was treated by a community center that had LINAC-based SRS. And so all the sites were treated with a fairly large margin of moderate dose going to the normal brain tissue. Essentially, the patient didn't have any recurrent disease intracranially or extracranially until he did present with a seizure. At this point, it was unsure if it was progression or pseudoprogression based on the standard MRI imaging, but we did a contrast clearance scan, and the lesions that were on the left side were suspicious for actual viable tumor versus necrosis, whereas there really was no evidence of viability to the treated lesion on the right side. So given the dose that the patient had beforehand, we were concerned about following this up with any form of external beam SRS, just due to the fact that the intervening parenchyma between the two right-sided lesions would be fairly high. This was the first time that we thought about trying to tackle two lesions at the same time with GammaTile. So we went ahead, did our pre-op planning, and it looked like that we would have pretty good sparing of the region in between the metastasis. And as you can see here, this is the basically on the left side shows the more anterior lesion, on the right side is showing the more posterior lesion, and the green line there is the 60 gray dose line, and we were able to adequately cover the area very well with the prescription dose, with very little integral dose going to the intervening areas. And Here is the CT imaging post-op showing that we were able to deliver 4 tiles anteriorly and 2 tiles posterior laterally. So to this point, the patient has remained on immune therapy, still has had no evidence of extracranial disease, nor has had any evidence of intracranial disease. So we are now this is one of our earlier patients. We were 4 years out from the initial brain metastasis and now 2 years out from GammaTile. And this is very, very, longer than what would normally be expected, longevity of having intracranial disease, and a testament to the durable control that GammaTile offers. Additionally, the patient does not have any real significant CNS toxicity, and this current MRI here basically shows just a little bit of uptake on the T1C contrast that is compatible with treatment effect. Now, to summarize this patient case, GammaTile allowed the application of a significant amount of dose to 2 separate lesions that were nearby each other, previously treated with SRS, without causing any significant toxicity, and delivering a very minimal amount of intrathecal dose to the surrounding brain parenchyma. And the benefit of this too was that while sparing the brain parenchyma, GammaTile was able to offer a much greater amount of biological dose than would be afforded by further SRS. And overall, we can say, at least in this patient, that GammaTile resulted in improved disease control over stereotactic radiosurgery. However, this really isn't what we would call an apples to apples comparison. In this case, the patient at the outside clinic, they did not manage these lesions initially with surgery, so we are comparing definitive stereotactic radiosurgery to a surgical resection followed by GammaTile. Interestingly, we did have another case around this time where we did get a very similar application where we could compare both SRS and GammaTile in the adjuvant situation. So this was a patient that had HER2 positive left-sided breast cancer, underwent lumpectomy with a negative sentinel lymph node dissection. However, unfortunately, she was found shortly after completion of her radiotherapy to have liver metastasis. So she was placed on THP chemotherapy. Then after that was followed on maintenance trastuzumab. After 2.5 years, she developed left-sided weakness and was found to have a 3.1 centimeter right parietal mass that you can see here on the T1 post-contrast MRI. She underwent maximal safe resection, and then this was followed by 2 stages of gamma knife radiosurgery. Because this lesion was high, as I talked about before, you tend to have less disease control using single dose SRS once lesions are bigger than 2 centimeters in size. So in our institution, we typically will do 15 gray in 1 fraction, and then follow up a couple of weeks later with 12 to 13 gray, which gives a pretty good EED to the tumor, but still not quite as much as what we can achieve with GammaTile. So 6 months later, the patient did develop some out-of-field punctate metastasis. These are small, sub 5 millimeter enhancing spots that were treated with gamma knife radiosurgery in a single fraction. After this point, the patient remained with no evidence of disease for about 18 months. Now, at this point, is 2 years out from the initial gamma knife radiosurgery following craniotomy, and basically was thought to just have treatment-related changes until the appearance became a little more aggressive looking, and contrast clearance scan was more compatible with viable tumor versus necrotic tissue. As you can see here, this lesion was causing a significant amount of edema that you can see on the flare, peripheral enhancement that was basically getting larger, and the contrast clearance scan showing a type of vascularity that was more in tune with viable tumor. So we decided to, proceed with recurrent treatment. Fortunately, this was in a very good place. for resection. So the decision was to proceed with maximal safe resection and apply GammaTile, being that gamma knife radiosurgery in 2 fractions was not enough to initially control the disease that she had at this site. You can see here that we used 4.5 tiles, and basically we're able to achieve a nice 60 gray coverage of the at-risk tissue. So now, interestingly, the patient sort of had what you could kind of look at as a internal positive control in a way. So she initially was treated with a maximal safe resection, had gamma knife radiosurgery. Now there's a recurrence there, and we treated with maximal safe resection and GammaTile. Shortly after here, she develops this left caudate nucleus metastasis, and that undergoes gamma knife radiosurgery. There's obviously in an area, unfortunately, that is eloquent, cannot do a resection. And while this lesion initially responded to gamma knife, it then ultimately 5 months later got larger, and so underwent a second round of radiosurgery treatment. So initially it was treated to 18 gray the first time, 17 gray the second time. Currently, the patient remains on trastuzumab. There is no evidence of disease recurrence extracranially. Intracranially, the caudate nucleus mass is, while still is seen on MRI imaging, its enhancement in size is going down, so it's consistent with treatment response. At this point, the patient is 2 years out from GammaTile and 4 years out from the initial brain met. So, in conclusion with this case, you're looking at a patient that in 18 months recurred with adjuvant gamma knife radiosurgery, and now is 2 years out with no evidence at the same spot of metastasis of having disease recurrence. Furthermore, after having a pretty significant dose of gamma knife radiosurgery, this patient was able to get treated adequately with GammaTile and has had really no CNS toxicity. In conclusion, this case really shows that GammaTile is able to safely deliver high doses to places that were both previously resected and also were irradiated to a very high stereotactic dose. Benefit of this really does not add to the integral dose on top of repeated SRS. We've seen this in several patients. Here's an example of our first gamma knife treatment where the patient had undergone both 2 different surgeries and 2 different rounds of stereotactic radiosurgery in the form of gamma knife to treat basically what was ultimately a grade 2 meningioma. And upon her 3rd recurrence, we were able to deliver GammaTile. And as you can see here on the left pane is the EQD2 combination of the 2 gamma knife treatments. On the right is that, as well as the EQD2 dose contribution from GammaTile. And as you can see, there's really no difference in the integral dose, the low dose spill to the normal tissue surrounding the patient's tumor bed. So in general, in another take-home point with this case is that GammaTile is leading to greater control than gamma knife radiosurgery after maximal safe resection, and it's doing this by delivering greater surface and depth dose while sparing the surrounding normal brain parenchyma. And when you look at other patients that we have, we're seeing the same thing, that we are getting a lack of recurrence in several patients that have had resections followed by gamma knife radiosurgery. The other thing I think is interesting in this case is that and typically when you have a recurrent brain metastasis to the same area, histologically that clonogen tends to be more aggressive. The interesting thing with this patient is that in developing that caudate nucleus metastasis, that was probably a newer clonogen, probably was more aggressive, and again, this shows the more durable control GammaTile is offering, in that we are several months out, no disease recurrence. That caudate nucleus site, although again was not surgically resected, got 2 series of very high doses of gamma knife radiosurgery, and now only after the second round of that is under control. So in summary, in the oligometastatic area, we're finding that intracranial metastases are more common. This is something that oncologists are seeing in their patients, but we are slowly getting more evidence of this from some of the larger trials, looking at different systemic agents, targeted agents, where they're seeing that survival is going up. This has been shown with breast cancer and with non-small cell lung cancer using targeted agents. But at the same time, we're seeing an increased incidence because of that overall survival in that patient population. Because we're dealing with an event that's becoming more common as these patients are living longer, there is a more significance to both the development of disease as imparting morbidity onto the patient, as well as the morbidity associated with retreating areas of metastatic brain disease. And as we're much better now at controlling extracranial disease, both with the targeted agents, immunotherapy, and aggressive treatment with stereotactic radiation therapy. More often now, intracranial disease is what's going to limit overall survival for patients. So having a platform like GammaTile that can adequately treat previously treated brain mets is going to be key. So again, in the oligometastatic era, GammaTile means that we're able to achieve the most optimal radiotherapeutic ratio. Essentially, we're providing greater dose than any other form of external beam radiation therapy used adjuvantly for after maximal safe resection of brain metastasis. But at the same time, because it is an implanted source, we are sparing more organs. And this is important not only in just decreasing toxicity from a single treatment, but this basically allows for a greater amount of treatments to come after the fact, both in the form of GammaTile treatments or, if they're not operative, SRS treatments, because of the decreased cumulative dose to these organs at risk. And so in centers like ours that have been extremely aggressive with immunotherapy and targeted chemotherapeutics, and very aggressive with extracranial SBRT and retreatments of recurrent disease, GammaTile has become absolutely indispensable for locally recurrent brain metastasis. If you have any questions about my experience with GammaTile at ECU, or anything GammaTile related, I'd be happy to answer them. Please contact the email that's listed below, and they'll get you in contact with me. Again, thanks again for your time.